Hello, welcome to the latest in the series of NR Times Roundtable discussions. And today we're focusing on designing a brighter future after brain injury. Today we're going to be focusing on improving post-ABI independence and quality of life. I'm pleased to say we've got a formidably experienced group of panelists with us today. They're prepared to share their insight and understanding with us. So I'm sure we're going to have a wide-ranging discussion on the subject of post-ABI care. I'm going to ask all of our panelists to introduce themselves, and after that, we'll get into the body of the discussion that we're going to have today. So if I could start with you, Pauline, please, from Elysium.
Hi, I'm Pauline Matthews. I'm the lead occupational therapist at the Bridge Care Centre in Middlesbrough. We are a care centre that specialises in neurological rehabilitation and complex ventilation tracheostomy care. I've been an OT for 20 years now. So I started off in the NHS and then I came over to Elysium, 6 years ago now. Elysium Neurological is sort of who I work for. So we've got sort of care centres and hospitals up and down the country.
Great, thanks for that, Pauline. Kevin, could we come to you next, please?
Hi, I'm Kevin Beckles. I'm a clinical psychologist. I work at St Andrews Healthcare in the neuropsychiatry division. I've been working there since 2021. And I particularly work with working age women who've experienced a brain injury, but have neuropsychiatric complications, so behaviors of concern, but also with men who have a diagnosed or queried dementia diagnosis, but also have behaviors of concern within that profile.
Great, thanks very much, Kevin. James.
Good morning. I am James Nocker. I'm a surveyor who predominantly writes accommodation needs reports for the High Court in personal injury and clinical negligence work, which I've been doing for more years than I care to remember now. But a large part of the firm and my enjoyment in work is adapting homes for individuals with a range of disability, ranging from significant brain injuries to the subtleties of a brain injury. And that very much informs the knowledge I gain from that, very much informs the evidence I present to the court in the reports that I write. And I have to say the practical side of the firm, the William Martin firm, is certainly a side that I thoroughly enjoy stepping into and I get a great deal of benefit from.
Fantastic, thanks, James. Hannah.
Hello, I'm Hannah Wright. I work at the Royal Buckinghamshire Hospital as brain injury coordinator. Have over 14 years experience of working directly with individuals with brain injuries. So started as a support worker and have worked my way up. Really interested in kind of like perma profiles and kind of really getting kind of quality of life really built. And also I really support with the complex discharge, planning around getting someone back into the community for post-rehab.
Great, thanks, Hannah. Heather.
Hi, I'm Heather Batey. I'm the Clinical Services Director of Reach Personal Injury Services. I am a neuro OT by background. I've worked in neuro rehab for 30 years now. Set up and ran Reach for just short of 30 years and then joined the Handel family. We provide home-based rehab services for clients where they have got head trauma through to concussion and then onto the more moderate and severe brain injury cases and also FND. We have a panel we've got a team of 75 neuro OTs work for Reach and a bunch of neuropsychologists. And really it's all about optimizing outcomes in the community. So I'm really excited to be part of this discussion today because this is really my bag about people further down the line and what their lives are going to look like going forward. So thank you for inviting me.
Great to have you with us, Heather. Thank you. And last but not least, Stephen.
Hi, good morning. Thanks for having me here today. So I'm Stephen Akerman. I'm one of the directors at the Barr Solicitors. I've joined them, I believe, in 2011. My journey to dealing with brain injury cases is quite interesting, or the firm, I should say. We started out really dealing with chronic pain litigation, fibromyalgia, and the way we sort of got into more brain injury cases is, as Heather mentioned, there's FND we see it more and more being diagnosed in the last, 12, 24 months. The way we got into it is with not so much traumatic brain injuries, which are very serious and very difficult and need careful handling, of course, but more from the subtle brain injury cases where it's not so obvious the physical injury. The psychological injury is more apparent, but it's the physical injury that's much more difficult to pin down. They don't show up on traditional MRIs or CT scans, and so we have to really convince defendants who are always skeptical of any claimant that there is an injury that is affecting their life, personality, or whatever, and then that can lead to a diagnosis of FND, which has its own challenges. So that's sort of how we got into brain injury cases is through that route. Of course, we deal with traumatic brain injuries as well, but more our specialties, more the subtle brain injury, and when it's more difficult to establish that there's a change in the person.
Thank you, Stephen. I'd like to go around all of our panelists and kick off by actually asking each of our panelists what they think excellence looks like when it comes to care, independence, and quality of life post-ABI. And we'll go around in the same order again, if that's okay, Pauline. And I apologise, Stephen, because I know it's always harder if you're at the end, but maybe you could give us a legal perspective on some of these things as well. But we'll start with you, Pauline.
Hi. It's very much individual based, isn't it? It's what matters to that individual. Trying to make sure that you've got a good, strong team of individuals coming together to figure out what's the best route forward. It's about trying to make sure that you've got lots of different resources at play. So you're doing work in the, for us here, we've got the gym, we've got the sensory room. We actively get people outside into the community as well. Thinking about bringing in, if they were close to their family members, having them part of the discussion from early on. What do they? Making sure that there's a good, strong element of education to help the family members understand what's happening with their loved one, and how they can be involved in the rehab and getting the best for their loved one, really.
That's a great way to kick off the discussion, Pauline. I'm sure we'll come back to some of those points. Kevin, your thoughts on excellence and what it looks like?
Yeah, I echo everything that Pauline has said. I would just say that I think from my experience of working in brain injury for a few years now, the importance of interdisciplinary working is so crucial. So particularly myself as a clinical psychologist in neuropsychology, working alongside OTs and physiotherapists and medics to understand the individual who's experienced a brain injury from a holistic perspective, and each profession kind of plug in a collaborative way to meet the need of the individual. So just an example is we have our activity center and our vocational rehab pathway at St. Andrews. And sometimes I think our service users may experience them as being silly, but then you think, well, what's the goal of entering this activity? So going to a crafting session isn't just about doing arts and crafts, it's about rehabilitating your fine motor skills and bringing vocation and meaning to your day and putting structure and all those things. So it's kind of having that holistic picture about what rehabilitation looks like. And Yeah, that I guess that's what my excellence is about the holistic, patient-centered or person-centered approach.
Thanks, Kevin. James.
I think it's a matter of trying to create independence and facilitate independence. Irrespective of the level of brain injury, the scaffolding has got to be put in place to enable the individual to maximize on their independence. And whether that's the multidisciplinary team, the OTs and case managers put in place, or the psychologists put in place, or their home environment, which is obviously my speciality. But they've got to work in tandem, they've got to work collaboratively, because irrespective of the multidisciplinary team and the rehab and the assistance that's being put in place, if we don't have an environment for that to blossom and therefore the individual to maximize on their independence, it's like a large pack of cards that just keep falling down. So I think excellence looks like creating independence, but it's also got to be the right medium to enable individuals to maximize on what they can achieve.
Thanks, James. Hannah.
I think it's about understanding the individual and their needs and their history as well. So really taking their whole life into account. I think collaboration within the team is obviously essential and within the wider team. So for me, it's about making sure that the future kind of support workers or the family are really aware of their needs and how to support that individual, and kind of just really focusing on life may not be the same, but it doesn't mean that life doesn't go on. And I think that's the thing. It's really kind of getting to grips with what is this new normal? What does that new normal look like, and helping the patient get to that point.
Thank you, Hannah. Heather?
Well, I'd like to just reiterate some of the things that everybody else has said, really. I think excellence looks different to every single person in a different way. Often as clinicians, we'll go and carry out assessments and identify areas of deficit which need to be worked on, but the client actually doesn't want to work on. So, for example, we might see the client could start to use independent transportation, for example, but that's not a goal for them. So they're not going to be motivated to do it. And so that's right that we go with what the clients want. And so really for me, excellence looks like providing the best intervention for that client for what they want to work on, looking at their goals, how we help them achieve their goals. Using technology massively now is key certainly in the community, and that's one of the things that we're picking up on more. But really, it's about something that I think it was Hannah said: the new you, the new self, the new normal. What that looks like, and I'm absolutely looking at quality of life, because we're only a few ones. We've got to have the best quality of life that we can have, and as clinicians, if we can enable that to an excellent level, then that's what we should be doing.
Thanks, Heather. We'll definitely come back and talk about technology, and maybe after we've heard from Stephen, we'll talk about some of the challenges and then come back and talk about innovation and some of the developments that are being pioneered. Stephen, your thoughts on excellence, and you might want to give this a slant from your perspective as a solicitor, like enabling factors.
Thank you. Well, the easy answer is all the above. I can just say what everyone else said. But just to, again, echo a little bit what others say, and then to add it from a personal injury perspective, because a lot of those principles apply to us as well. Taking the individual into account is so key. We get so many inquiries. People, well, I saw this on your website and that was the outcome. So I'm exactly the same. Therefore, the outcome should be similar. And of course, the underlying principles are all the same. Diagnosing the injury, getting treatment in place, care providers, accommodation. Of course, that's all, the underlying principles are all key. But what's so important is applying it to the individual and their individual circumstances, because no two people are alike. It's just, they can have the same injury, but how it affects them, both physically and mentally, can be completely at odds. So I think the first thing is really getting a grip about the individual. part of that is what we do is in personal injury claims, again, which is very helpful because, again, unfortunately, defendants come at this as the person is over-egging the pudding, rightly or wrongly. That's not what today's discussion is about, but that is the reality, and we have to work within the reality. And what we try to do is, and I think it's therapeutic to these people, to these individuals, is focus on the positive. Human nature is always to focus on the negative. We all do it, no matter whether we're healthy or whatever. It's just human nature. And I find it's very therapeutic when I take their witness statement and say, I understand you're disabled to a degree, and I'm not downplaying that, and we have to for sure take that into account, get the right team in place, the right help in place, but also let's look at what you can do. And it comes back to what James was saying about independence. It's so easy to just let the condition take over, and I see they believe they are disabled, and of course they are to an extent. But once they realize what they can do, it helps them both physically and mentally, and it helps them maximize the new you, as others said. And then they can really, have a very, very good quality of life. I've seen it so many times. So I think excellence is again, independence and individuality, I think, are really, really key.
Thanks, Stephen. James, did you want to add something?
I just wanted to put another layer to something Hannah mentioned. The importance, we shouldn't underestimate the importance of the affects a brain injury has on family members, whether that be children or siblings or partners. That ripple effect that a brain injury, irrespective of the extent of brain injury, it has a huge underlying effect on family members. And when we're dealing with specific individuals, we really have got to doff our caps to the fact that this affects a lot of more people than just that one character. So important we don't forget that or lose sight of that.
Yeah, great point, James. I can see everybody nodding in agreement. We've talked about what excellence looks like, and we will come on to talk about innovation and some of the developments that promise a brighter future. But before we do that, and I won't go around the panel, just open it up to talk about the challenges in realizing that excellence. So can I just open it up and ask some of our panelists to talk a little bit about some of the challenges that they face and clients face, and indeed, as James says, families face as well?
Shall I kick off with a few comments and other people can then pick up from me? I think the challenges for us, because obviously I worked in the NHS and worked in social services, then moved into the independent sector, and I've been in the independent sector for about, like I say, 30 odd years. And the challenges are really getting the funding in place. This will resonate with Stephen and everybody else is nodding, for the right intervention for that client. Often we'll go and do neuro rehab assessments and make recommendations to case managers, to solicitors, to insurers. And we're looking at it from this is the best service to have the best outcome. And then we get information back. Can we do it for less? Can we do it less intensity? But that has an impact on outcome. And so it's important that we can get our clinical reasoning documented efficiently to make that a clear guideline for the stakeholders and the funders to be able to say, yeah, we agree with what you're saying, we can see where you're coming from, and let's try this and let's review. And then we can start to show what we're made of. And I think within this industry, there are a lot of stakeholders involved. But as clinicians, we just want to have the best for our client, and it's making sure that our recommendations are being heard, are being understood. And I think that sometimes comes back to us clinicians to make sure that we're getting that message across in an effective way. So it's a learning opportunity for us as well as others in the marketplace. And I think really by having maybe some of the stakeholders not having such a good understanding of what rehab can achieve, again comes back to us providers, our clinicians, to make that happen. So there's a bit of responsibility across the board, I think, but funding and getting services in place at the right time is key.
Yeah, I could see a lot of heads nodding vigorously. Hannah?
To add kind of to that point, what I often find is actually people who don't have a case manager or who don't have an insurance claim, funding for them is almost impossible. Rehab is almost a pipe dream if you don't have a case manager. Getting CHC funding for a patient with a brain injury is one of the biggest challenges that I face.
Thanks, Hannah. Stephen.
Sorry, thanks, Pauline. I saw you unmuted quickly. Just follow on what Heather was saying, just to defend fellow solicitors about coming back. Unless, I mean, as you all know, doing the work for claimants is that now, especially, there's cost budgeting, and the courts take a view. Well, I'm not making any judgment on the fees. I know what goes into it. There's a heck of a lot of work. I respect it, and I don't think people are overcharging, but the courts do what they want, and the defendants are obviously saying, well, this is not necessary. It's really not that bad. It's not as severe as you're saying. You can just calculate it yourself. What do you need a care expert for? You can just, figure it out yourself. And sometimes there is merit, and sometimes they just want to keep costs down. So I think usually when we go back to solicitors, even though it's theoretically privately funded to an extent, we still have budget issues and we still have cost constraints. And, there is a finite amount of funding, even in PI claims. We have to work with what we're given. And to be fair, I think I've been to OTs, architects, and they understand the situation. And if you're just open with them saying, listen, this is not us challenging your fees, we understand, but this is the budget that we have. Can we make it work within it? And most people are very, very reasonable. I find just being open, sort of counteracts that to an extent. But everyone's trying their best, and I think so. The barrier is unlimited funding would always be the nicest thing for all these things, but that's not a reality. But I think the best way to do it is just putting all the cards on the table, having a telephone conference, and I find that usually people have the client's best interest in heart, and money is not the be all and end all. And if they can make it work, they will absolutely make it work. And I think that's really key.
Well, maybe to pick up on that point as well, Stephen, communication should be added in there. So, rather than it just being so, a good communication, good conversations about the best way forward within a finite area would be really useful.
Absolutely.
I think I couldn't agree with you more with a collaborative approach. It's essential just to get some joined up thinking. But just to answer Alistair's question with regards to challenges, it's getting the establishment, for want of a better expression, to understand the complexities of a brain injury. And from a housing point of view, which again is my area of expertise, when we're adapting a home for a spinally injured individual in a wheelchair, for example, as long as we get level access and as long as we widen doors and we have sufficient space, we're almost there. And without wanting to belittle that, it's not rocket science. But when you start dealing with the brain injured individual, that's where the challenges present themselves, because it might not be the size of room. It may be where we put it in juxtaposition to bedrooms and living rooms. We might need a quiet space. It's the detail in that room that then becomes important. And where funding's concerned, the local authorities facilities grant, all they see is the physical disability, that we need an ensuite bathroom, or we need level access, or we need an additional carer's bedroom. But they miss entirely what Hannah touched on and Heather touched on. They miss the subtleties and the importance of the brain injury. It's almost a forgotten relation in this disability world, because there's no requirement for wheelchair, there's no physical disability insofar as space requirements. Their needs at home are equally as important.
That whole area of understanding from what you call the establishment and communication seems quite crucial, particularly when understanding not just the complexity, but the fact that these are very long-term needs that, will be pathways and care required for decades. Pauline, did you want to come in there?
Yeah, just building on what the others were saying, really, I think if someone hasn't got a case manager kind of fighting for them, especially for the funding side of things, they're kind of already on a back foot. And then the pathways, as you touched on there, Alistair, obviously we're going from, in an ideal world, there would be that streamlined pathway from NHS provision through to private independent provision based on the specific needs of that individual. It shouldn't be a case of having to tick so many boxes. And as James was saying there, those hidden disabilities, the cognition, the visual impairments, perceptual impairments, if you're not working with a case manager, or, an NHS CHC review person who has a good background in neuro, then it's really tricky. And we have to be very detailed and in the way that we write the reports and our goal setting. But as I say, unfortunately, a lot of the time it is about physical goals, and we really need to raise the profile of ABI is not just physical; it's that holistic view again.
Right. Well, James, if I can come to you to pick up on the question of challenges and following Pauline's comments.
It was very useful to run through that very interesting list of the hidden disabilities. But one I think everybody misunderstands is fatigue and how that affects the brain injured individual in all walks of life. And the challenges faced with fatigue is really a mountainous effort.
Yeah, and to add to that as well, James, it's not just physical fatigue, it's cognitive fatigue. And that's sometimes unrecognised as well. So it's both areas.
Yeah, just to add to that, when I was a teenager, I was actually knocked unconscious. I was playing. I don't remember. As will happen with a lot of people that have traumatic brain injuries or brain injury. I don't remember. I still to this day, we're going back 25 years. I still don't remember what happened. People told me what happened. I just remember waking up on the ambulance stretcher. They came and it took me. Thank God it was okay. No permanent damage. But I remember thinking they took me to the hospital, did a CT again. Thank God everything came back fine. And I thought I was okay, but I remember for the week afterwards, I was just felt awful. I couldn't function, and I was a teenager. I wasn't how old I am now. I was a teenager, and just imagining people going through that all day for the rest of their life, every day to some extent. And I remember like 4 o'clock, I couldn't move. I just couldn't move. I just had pounding headaches, and it was awful for about a week. But thank God, I made a full recovery. But the people that don't and have that ongoing, I can only imagine, what that must be like and the support they need.
Thanks for sharing that, Stephen. We've spent a bit of time talking about challenges. Just before we leave that subject, is there anything else that anybody wants to address?
I was just going to say that I think what we've been talking about those hidden disabilities just really highlight just how disabling our environments and our society tends to be, not only for persons who've experienced a brain injury, but any difficulty that puts them outside of the norm. It just highlights and puts a mirror to how disabling our environments can be, and how, I guess, superficially we look upon individuals and people. We don't look beyond behavior. We don't look and kind of consider what might be the cause. We often jump to the most negative or pejorative explanation: alcohol or substance misuse or person just behaving badly, and we don't think, well, this person has a lived experience. What might have brought them to this point? I think that's all really interesting what everyone's talking about, because it just highlights that so clearly.
Yeah, thanks for that, Kevin. Pauline, did you want to add something?
Yeah, I'm just thinking not just about the individual themselves that's had the injury, again, going back to the families and, the friends. there's such a postcode lottery still. I know we've used that, term for so many years, but it's unfortunately still around in terms of the rehab and care provision for the individual, but also for the families, making sure that they're getting the right support that they need. And I think we've still got a long way to go for that.
Can I just pick up on that as well, Pauline? And really one of the challenges, I guess, is getting a really good transition from hospital to home and that pathway. And that covers the client, the family, it looks at resources, the lottery aspect, because as you say, some people get discharged into home and there's nothing there. And then they become a revolving door. And whether that goes back to Kevin's point about maybe somebody's resilience, their coping mechanisms, or even go back to his mental health once they're back in the community, if there's no services there, they're going to end up being back an inpatient. The cycle starts. So the challenge also is having that really good, smooth, scaled clinical pathway from hospital to home, enabling the best outcome.
Great.
Sorry, Alison, that's so true, isn't it? Because particularly in not only the clinical negligence, personal injury world, but in the practical side, people blossom when they get home, as long as there's a suitable environment to blossom. All the hard work and all the effort that goes into rehab in that transitional period, it's lost very quickly if we put a brain injured individual into a home environment that's unsuitable. And if it's an unsuitable home environment, it's unsuitable not only for the individual, but also the wider family and siblings. That must be very challenging for particularly you guys that have got to put it into practice.
Yeah, thanks, James.
Yeah. And just to add on to that as well, you say it's about the environment, but also trying to get a care package. If they haven't got the legal kind of funding behind them, and they're relying on the sort of standard NHS care package of 2 carers 4 times a day, and then we have big fights on our hands to try and justify the need for overnight support in some cases as well, and that actually the family members can't be, that they're often going out and living their lives and trying to work and juggle childcare and whatever else we all have to do in day-to-day life. But yeah, it creates massive barriers to getting people home and being able to live that full quality holistic lifestyle. They're already boxed in, unfortunately. Not in every case, but too many cases.
Thanks, Pauline. Stephen?
Yeah, and that issue I think that Pauline was just speaking about is maybe even worse. It's magnified 100-fold probably when we come to subtle brain injuries, because defendants already are fighting on funding, and then they say, well, is there really anything wrong with the person? I know that sounds quite cold what I'm saying, but these are actual arguments that I get. I'm not even embellishing. And they question whether there's even anything wrong with individuals. So to get then funding for even forget a holistic package for anything is really hard. And then obviously these people are really affected already. Depression, they can't work. We even see personality changes. And it's just a massive challenge. I guess to be charitable, I don't necessarily blame the defendants for taking that view, because there are no scans, and unfortunately there are people out there that do try to game the system. A very small minority. I accept that, and they don't want to pay out hundreds of thousands of pounds, if not millions, if the person is not honest. So I do understand it, but sometimes it can be taken a little bit far, and nothing we can do can prove our client's honesty. And until we get to a settlement, which could be 3, 4, 5 years down the line, we can really be without funding. It just magnifies all those challenges, 100-fold.
Also, on that point as well, as you say, there are no scans to highlight. At this point, there will be soon, but at this point, there's no scans at this point to highlight a concussion or a mild head trauma and the impact that that's had. But if you look at it from a functional perspective, and clinicians will pick up on areas of deficit and areas of ongoing difficulty, and then we can start to look at how we can make things better. that client. And obviously you look at the client now compared to the client pre-head trauma. But if you leave that client with nothing, then mental health issues can start to kick in. And as they progress on, there can be lower mood and anxiety, and that has an impact on their job role, that will have an impact on their relationships. And very quickly, their lives become magnified in terms of the disability that they've got. And that's when it's difficult for perhaps funders to say, well, this is the level of incident and accident and the outcome. And now look where the client is 2 years down the line. But that's because nothing has been done in between. And it's almost that secondary evaluation and the secondary issues that become more prevalent. So it's getting involved quickly with these types of clients to kind of head off at the pass. I think it's really important. And that comes back to early assessment. I think everybody, all the clinicians certainly on the call will look at early assessment is important.
I think also just going back to what I mentioned earlier, getting the establishment to understand the subtleties of a brain injury. Stephen's talking eloquently about getting the defendants to fund environments and care. The local authority are no easier. Getting a disabled facilities grant for an ensuite bathroom for a wheelchair-dependent individual is difficult. But getting the local authority to fund maybe an activity pod in the garden so a brain-injured individual can go with therapists and continue their rehab, or simply to take themselves away from the anxiety of family life when they just need a little bit of time out. Those two elements of a case are equally as important to that individual. But getting the local authority and getting the funding for that is even tougher. It's so hard because of the lack of understanding of what the subtleties of the brain injury, but also what we need to put in place to enable them to maximise on their independence.
Thanks, James. We've had a really sort of explicit discussion there about the challenges. I'm quite keen that we give a bit of airtime to talking about those things that are now pioneering approaches, developments, improvements, innovations, the things that are actually tackling some of those challenges or improving quality of life. Hannah, I saw your hand going up, so I don't want to shut it down if you want to get a last comment in about challenges before we move on to maybe more positive aspects.
Okay, I'll be quick. I was just going to say it's quite important as well, like the individual themselves to understand their disability. Often what I see is people will accept the physical side of it, but be very hesitant to accept their kind of brain injury and how that will affect their cognition. So I think that's another challenge that we have to add into all of this.
Great, thanks, Hannah. So if we can move on to new approaches, developments, innovation. You talked about technology, Heather. Can I just open it up? And if anybody wants to give some practical examples that they've worked with or have been party to, that would be great. Heather.
Yeah, well, so we held our conference last year, and the early part of the conference was on FND, and the second part was on innovative technologies. And we've got a digital technologist working with us who's also an OT. And it's amazing. And I don't mean big pieces of kit. I think for me, working in the community, quite a lot of inpatient therapy services have big pieces of kit that are really useful, great outcomes. But that client has to go home, and that client has to then in their own life and maintain what they achieve in the residential setting. So it's important that care is followed through. And there are so many pieces of technology that can be used to help the client become more independent from a cognitive, executive functional point of view. And I don't mean difficult things. I don't mean things like you expect them to be able to tell you about. It's easy pieces of Alexa, for example. You know, I use Alexa to turn on Radio 4 or whatever. But Alexa can do so much more, and and that can empower somebody to be living independently. We had very quickly, we've got a girl we're working with in Ireland, and she's got very, very poor communication skills, and she wouldn't go out in the community because she can't communicate very well. And we used a company voice it. And they linked into Alexa, and she was able to link her voice through voice it to Alexa to give instructions. And she loved doing things like baking and watching soap operas and things, but she had to rely on somebody else to turn the oven on, to turn the kettle on, to turn the TV on. And she could use the technology to do all these things for her independently. And that gave her a huge boost of confidence in order for her to feel comfortable about going out and communicating with other people. And so it's almost like a medium to help move forward. And as clinicians, certainly within the College of Occupational Therapists, Pauline will be aware of this, it's within our best practice guidelines that we as clinicians should be considering technology when we work with a client now. And that's part of our code of best practice. So technological solutions are really important, not just physically. I don't know much about the physical aspect, and James will probably know more about that, and maybe Hannah and Pauline as well. But from a cognitive executive point of view, and even probably links in with me on this one, there are so many opportunities that we can help clients make and action decisions that they want to be able to do, and that empowers them so much more, and that leads to better quality of life, and that leads to better outcome for everybody.
Thanks, Heather. Pauline?
Yeah, isn't it great how the technology's advanced so much that is something that it's accessible pretty much to everyone now as well. You don't have to have a lot of money to be able to invest these things into a program. And yeah, I mean, a very similar view to you, Heather. You know, I do like the big fancy pieces of kit and things, but actually it's the little things that make such a big difference to the quality of someone's life. And, you know, most of our residents here, they will use electronic calendars where they can have a visual representation of what day it is, the time, and, you know, whether it's afternoon or morning, and what the year is, the date. You know, we've got talking versions, or where you say you can ask Alexa what the date is now, can't you? But you know, mobile phones, you can plan all sorts into them, can't you? You know, different diary options and reminders to do things. So yeah, just echoing what Heather's saying there, really.
Thanks, Pauline.
I'll jump in there. I think on this subject of technology, we have one of the most powerful aids in our hands most of the time, and that's a smartphone. And that's for accessing resources that help with psychoeducation, help with more practical functional tools like Heather and Pauline have described in terms of calendars, and helping people to remember and schedule and do those planning, sequencing tasks. But just to kind of pivot away from technology a little bit, one of the things that I've been thinking about in brain injury, and I think we've highlighted it here today, is the holistic, systemic factor of brain injury. And what I have experienced and what I'm hoping to do more of is systemic family therapy in the context of brain injury. So I know that there are some psychologists who've done quite a lot of work, particularly with couples, around brain injury when one party has been brain injured, to help understand the subtle nuances and differences of who your partner is becoming as they recover from that brain injury and managing those relationships. But I do think that is really crucial because, as I mentioned before, in terms of that kind of mirror to society aspect, it's also an opportunity for people to essentially create the life that they really want to live. I think many times people come to a brain injury having lived a life that they may have really enjoyed, but also may have not enjoyed. And we can see this as almost like a reset moment. Not that everything has to have a positive spin on it, but you can take this opportunity to take stock. And one of the modalities that I use is ACT, acceptance and commitment therapy, which is kind of rooted in values. And when we get people to think about their values, you get them to be excited about the life that they're about to live because it's in line with those values. It may not be as, I guess, visually productive as their life was before, but it's meaningful. And I think that that's a really wonderful opportunity that we have as people working in this space to help people build a life that means something to them, even in the context of a brain injury.
Thanks, Kevin. Hannah?
Kind of following on from that, I do a lot of PERMA profiles. So it looks like it's an emotional well-being construct. So it looks at things like what brings someone positive emotion, engagement, relationships, meaning, activities, etc. And to sit with the patient and go through that and create goals for each of them things, which is only going to increase their emotional well-being. That's such an important, it really kind of highlights like what's important to them now and how do they want to move forward.
Thanks, Anna. Stephen?
So first and foremost, I think from a personal injury perspective, I think what Heather mentioned before about new tests coming online to indicate and essentially prove injury, T3 scanning we have sent clients for those scans, very expensive, but well worth it. And they don't always show an injury, and it doesn't mean just because it's negative doesn't mean there isn't, but it's definitely much finer than the standard MRI, and it's definitely working wonders. Hopefully that will become more mainstream and more affordable as time goes on, as these things usually do. But I think interestingly, obviously COVID was very difficult for everyone, but a positive, if I can say that came out of it, is that it's more accepted to use technology for everyday things because of COVID, like what we're doing now. Obviously, video conferencing was a thing beforehand, but people that have anxiety meeting people now will feel much more comfortable. It doesn't even cost anything because to do these, but just from a therapeutic, I see with clients, it's just the willingness now to engage a lot more with new things that come online, technology, because it's so much more accepted because of COVID. Again, it was a horrible experience, but if it happened, so we might as well take the positives. And I think that is one positive that came out from that experience.
Yeah, I totally agree with that. And to the point where I was over at the brain injury in New York a couple of years ago, and this was just before the pandemic, it's a few years ago now. And there has always been the question of, can you deliver rehab remotely? And in the sector, certainly with the moderate and severe brain injury cases, you would say that actually you need to be in person is so much more effective. But the pandemic has showed us that we can run rehab programs where a clinician is in one town in their house and the client's in their house, and you can actually make that work. You can be creative and make it work. And actually, remote rehab has been operational in loads of different countries for a very long time with really good outcomes. For example, in New Zealand and west of Canada, they've got one or two clinicians covering hundreds of thousands of miles. I think Cumbria is quite remote. Well, it's nothing compared to the west coast of Canada and New Zealand. And they use remote technology and telehealth really well. And so that's really given us, as you say, Stephen, that's really given us a bit of a kudos to be able to move forward. And pre-pandemic, all of our concussion assessments and sessions were face-to-face. And now they're all over video platforms like this, and we get great outcomes because it's much more flexible. People are in their own homes, as James said, people function better in their own homes. We get more from them, into families. It actually works quite well, and by using sort of video technology, you can get so much more from clients, all sorts of different things, but also you can make you more comfortable, and it's that comfortable aspect. Sometimes if I feel I know you guys a little bit more now, if I saw you face to face, it would be I don't know what's the word, anxiety provoking, because you've already crossed that boundary. So yeah, technology is just the way forward for a lot of brain injury clients, both emotionally, from an executive and a cognitive point of view, but also, James, I guess, from your point of view as well.
Pauline, did you want to come in, and then we'll start to sort of pull the discussion together in a summary? Pauline.
It was just a quick one to say about how obviously technology advancing has also meant that those with communication problems, we're able to hear their voices and hear their thoughts, their wishes, so much more as well. And, being able to embrace that, it can only be good, can't it?
Thanks, Pauline. We've spent quite a bit of time talking about excellence, about challenges, and about new and positive developments. So I'm going to ask all of our panelists in summary to say a few words about the future and their optimism and the one or two things that they feel would make a really big difference to ABI care and to quality of life in the future. It might be things that you're actually doing at the moment, things that you can forecast confidently, or things that you see developing. So I'm going to go round the panelists in no particular order, but if I can start with you, Heather, and then I'll work round all of the panelists. You're on mute, Heather.
Oh, I tried not to do that. Okay. I think a couple of points. I know that time's of the essence here. For me, I think to get the best possible outcomes, looking at opportunities and innovation going forward is early assessment, not allowing clients to drift. Early assessment, identify what the difficulties are, and then have get the clients on a treatment pathway quickly. And we see this more and more with the FND cases as well. Early diagnosis, treatment pathway, crack on looking at areas that are important to the clients, has to be client-centred. So early assessment, client-centred, and also championing technology, because that is key to the way forward for our client group, absolutely key. But I'm not taking away from the family relationship issues that have been mentioned specifically by Hannah and Pauline either, because that is really, really important. Social contact and social development is so key within a client's rehab journey going forward, and that will look very different, possibly pre-accident, but that's got to be part of their life post-accident in order to optimise quality of life.
Fantastic, loud and clear, Heather. James?
I certainly endorse the IT and the apps that are now available, and they are kicking down boundaries, which the more we remove from any individual with a brain injury, it's got to be applauded. Key points, certainly collaborative approach. We've got to have some very good joined up thinking when we're resolving the negative effects a brain injury brings. I think a greater understanding is essential, from fatigue to anxiety to all those residual difficulties a brain injury brings along with it. We've got to start understanding those better. And when we start understanding the effects it has on a lifestyle, we can then start putting the scaffolding in place to fix it and to make that pathway into that new life, which Kevin touched on earlier, into that new life and that new horizon, easier and smoother.
Great, thank you, James. Hannah, can I come to you next, please?
Yes, I think one of the things that I would like to improve would be kind of access to kind of statutory funding for patients with brain injuries, particularly, like I said, people who've had strokes or tumours and things like that, that don't necessarily have funding via an insurance claim. I think funding for them would be really important. I think, like we said, continue with that interdisciplinary teamwork, education around brain injury for individuals and their families, and kind of their supporting structures around them would just be key to kind of keep their lives moving forward.
Thanks, Hannah. Kevin? Kevin? You with us? Can you hear me? I'll come back
Sorry,
to
I
you.
don't know if you can hear me, but I've lost audio. I can't hear what you're saying. But
Okay.
if we're still talking about key points for the future moving forward, I would highlight perhaps having a national brain injury strategy and thinking about our environments and the world that people go back into after a brain injury would be something that I would like to see more firmly established, so that a lot of the issues that we've talked about in terms of pathways from the injury to early acute care to long-term care in the community, that trajectory will be smoothened, hopefully, with that enhanced education and understanding of what persons who've experienced a brain injury need. I think just wider societal education around hidden disability would be really important, because alongside the individual work that needs to happen for the person who has experienced a brain injury, we've talked about brain injury not only affecting the person, but the system around them. And if we're not addressing that system, we're setting the person up to fail. So that's about helping families to understand what to expect from the individual, adjusting their expectations of what a meaningful relationship with that individual might look like, so that they're not having a negative impact on the person's emotional well-being and therefore negatively impacting their functional and cognitive rehabilitation or recovery. So I think, yeah, those systemic issues around education, creating the environments where people can flourish would be really key moving forward, along with the technology and everything that we've talked about.
Thanks, Kevin. Even if you can't hear us, you've done very well there, understanding where we were in the discussion. Stephen, you're one or two things that you'd like to see happen that you think would make a big difference.
Yeah, pardon the pun, but I think people need to be a bit more open-minded about brain injuries and about how it affects people. I understand the skepticism. People are always afraid of change and people are set in their ways, and it's been like this for the last 50 years, and I get it. And you can hold on to that if you want, but at least accept the possibility that maybe things need to change and make, hear the arguments. Don't come into the discussion with your mind already made up. And I think people just take a step back, voice your concerns. That's fine. Everyone's allowed to have their opinion and everyone's allowed to have their concerns. And I would say a lot of them are legitimate concerns, but we're learning new things every day, and we have to take that on board and adjust to the new information that we have. And I think if people just can just relax a little bit and try to take all that on board and not saying that they were wrong, they were right when things were the way they were 10 years ago, but being right, the right thing could be different now with new information that we have, and it's not contradictory. It's called growing and taking things on board, and I think that would be massive from everyone's perspective.
Great, thank you, Stephen. And you get the last word, Pauline.
I am going to echo a lot of what the colleagues here have said. For me, I think we really do need to continue building on those pathways from the moment someone comes into hospital all the way through to that end of all the way through the journey back into the community and back into life. So we need to really build on those partnership pathways of care from through every sector. Technology has come a long way, and we have we are learning to very much embrace that, and there is some really good positive moves from technology coming forward, and how that can have a really big impact on the way we work and getting better outcomes for the people that we work with and their families. Just thinking about, we have more people that have a growing understanding of brain injury and how that affects people, but we still have some way to go.
Thanks, Pauline, and thank you to all of our panelists for that summary. That sounds and feels like a manifesto, so I hope any decision makers or legislators that are listening to this absorb what's been said and take steps to act. On behalf of NR Times, I'd just like to thank our panelists who have been fabulous today. I'd like to thank them for being so generous with their time and their insight as well. I'd like to thank everybody that's watching, both our panelists and everybody watching. Please Share this as widely as possible on social media and all of your other channels. This discussion deserves to be seen and understood by as many people as possible. It'll be available on the NR Times platform and on YouTube. So it just remains for me to say thank you once again to our panelists. I hope you've enjoyed the experience and the discussion, and I'm sure there'll be other discussions that follow some of the strands that we've explored today. Thank you.